Congratulations, Zanchen. Excellent planning and excellent execution. We are discussing when you are absent about the need or not to insert a interarticular fusion with a cage in case of a flexible C1, C2 dislocation by orthodontoidium. We are discussing that in your absence. What do you think? In every case, you need to insert a cage, or only in a very specified situation you do that stronger biomechanical approach with a cage? What's your opinion? You use in every case, or you select the case?
I use almost in every case to plant cage in the first joint. For the reducible C1C2 dislocation, it's very flexible. Input cage can make bone fusion more certainly. So with cage implantation, we can get a more stable reduction. For the cases with basal imagination, we need to implant a large cage in the first joint to reduce basal imagination with the height of the cage. That's my opinion.
Thank you.
There are two questions from the audience. One is that if C1 lateral mass screw fails, if you cannot place a screw on the C1 lateral mass, what's your second option? Is it a C1 posterior arch screw or occipital screw?
C1 lateral mass is in my opinion, I never fusion across segments. If C1 is fusioned with occipital, I will choose condyle or occipital bone to perform the fusion. If the C1 are not fusioned with occipital bone, we will fusion only C1 and C2.
Okay. Well, another question is, how do you decide the dislocation is reducible or not before surgery? Is there a preoperative evaluation if it is reducible or not?
Yeah. With every patient, we should check extension and flexion X-ray to evaluate whether it is reducible or not. And but at the same site, it does not have any influence of my strategy for the surgery. For most of our patients, in the operation, we manipulate in the first joint. Even irreducible cases, we can reduce it with the distraction between the first joint.
Can I make an observation, please? In 1996, we studied several cases, so-called irreducible C1, C2 dislocation, that as a matter of fact were truly irreducible in traction, in X-rays room with the patient awake, in operating room with the patient sleeping, but they became reducible during operation in prone position with the head extension of the neck and little bit flexion on the chest with the Mayfield headrest traction under cularization, and such circumstances with the help of surgical tools and intraoperative traction, drugs, and surgeon also lucky or ability, it is possible to completely reduce so-called irreducible preoperative C1, C2 dislocation. Another observation of the Savage strategy, exit strategy, in those cases where the C1 lateral mass skewing is not possible. In those cases, the Benzer techniques, both skewing of posterior arc and C0 occipital condyle skewing should be a solution according to the observation of Zhan Chen. We have to pay attention to the hypoglossal nerve when we deal with the occipital condyle skewing, but we don't have to forget an evergreen technique, old-fashioned but evergreen technique, which is called posterior arc of C1 wiring technique with the old-fashioned Songer cables or titanium cables. We can we can reach a good realignment and an effective and very impressive stable reduction. This is my invite to use as a tailor do when he works on tissue, on dresses, clothes, but we have to use everything we have. Also, old-fashioned, apparently old-fashioned surgical strategies. This is my personal opinion.
Thank you
thank you.
very much, Milano. You are absolutely correct. It is needs to note that nowadays, the preoperative evaluation of C1, C2 dislocation is not so important, irreducible or reducible. As you said, after anesthesia, many patients become reducible. And additionally, using the fixed joint manipulation, many irreducible dislocation becomes reducible. So the preoperative evaluation is not so important nowadays. Thank you for your comment.
Yeah, this is also my intention. Yeah, everything you decide in the surgery. You cannot decide if it is reducible or not before surgery.
And I and Luis have the same experience. The intraoperative skull traction is very useful for intraoperative perform the reduction. And in my opinion, I never use instrumentation to perform the reduction. We should release the first joint first. With release the first joint, we can reduce the dislocation, and then internal fixation only to keep this reduction position, and with the support of the first joint of the cage in the first joint, we can keep the reduction stable. Because with the internal fixation system to reduce is not so stable, because too much strength was loaded on the internal fixation system.
As for reducible or irreducible dislocation, I agree with Dr. Fengzeng. Several years ago, I think in the world, I will give the patient a skull traction. Even heavy weight, it cannot have a thorough reduction. I will prepare a transoral instrument. Perhaps I will perform a transoral surgery. But in recent years, I will prepare I will decide if the patient is the reducible or irreducible. I will, under the anesthesia, I will give him a heavy skull traction, such as the patient yesterday. in the operating room. I gave the patient 12 kilogram skull traction, even so heavy heavy weight, about 1/5 of his body weight. It cannot have the steroid reduction. So I think she is irreducible dislocation. So I think if the patient is reducible or irreducible, it can be decided in the operating room under anesthesia. I think it is important. Then the traction weight can be the 1/5 or 1/6 of body weight. I think it's a good method.
Okay, Mehmet, I think it's time to close the discussion.
Yes.
Could you please give us a speech at the end of this seminar?
Yeah, I congratulate our Chinese friends in Beijing, Dr. Fengzeng Jian and Dr. Zhan Chen, for very nice organization. I wish to meet in the future meetings. It was great to be with all nice speakers. Very excellent experiences they had, and they shared their knowledge. I'm very happy to listen and learn from them. Thank you.
Okay, thank you, Mehmet. Now I'd like to show you we really have a very successful seminar. Until now, we have more than 11,438 online clicks only in China. So this is really great successful seminar on craniovertebral junction. I'd like to thank all the members of our faculty, and I'd like especially Professor A and Professor Jian. Yesterday, they performed 2 live surgery demonstrations with very good clinical outcome. Finally, I'd like also to thank all the participants online, not only online in China, the Chinese colleagues, also the colleagues worldwide, both neurosurgeons and orthopedics. Thank you all. See you next time.
Bye.
Bye.
Thank you. Bye, everybody.
Bye-bye.